So to get us started, I am just briefly going to run through these CME slides, and we will also distribute the handout that has the same information so that you can get your CE credit for attending today. So as a reminder, in order to get credit for attending this lecture, you would text 71203 to the number on this screen, and they give you a day to do this. So if you can do this right after the call or even right now, that would be great. And then you will complete the evaluation online by June 9th in order to get credit through your Beaumont CME account. And for continuing education credits for this presentation, we're able to give medicine CME, nursing CE, pharmacy CE, and dietetic CPEU. And as far as disclosures, so Dr. Ashman, who is our course co-director in planning these learning community events, has stock in publicly traded companies as listed on this slide. And with that, I'm going to stop and hand over sharing to Heidi Diaz, who is our co-director of MCT2D and who will be leading today's panel.
Thanks, Jackie. Let me get this queued up. Can everybody see? Oh, it's in.
Do you want it to be full screen?
Yeah, I'm surprised.
Go down to the very, very bottom, and there'll be 3 little dots that appear, I think, on the other side of the window.
3 little dots. Oh, geez.
Down at like the bottom of the bottom of your screen, like near the bottom of the presentation, is where it shows up.
For some strange reason, it's not doing it.
If you want, I can share screen instead.
Yeah.
Yeah.
I guess so, Jackie. Sorry about that, everybody.
I can do that, no problem. And then just to give everyone some context in case everyone doesn't have this background for the content for this presentation, I'll put the CME number in the chat, Dr. Haber. For this is the first of 3 learning community events that we're doing around one of our specific quality improvement initiative focuses. So this one's on CGM. We have one next month on medications and then one in July on low carb diet. And back in September, each physician organization chose a QI initiative that they were going to set a specific goal around and focus on working to improve in that VBR year. So from September to June. So the POs have worked with their practices to come up with different process changes that they might want to make or things that they want to focus on accomplishing during this year related to that quality initiative. So now that we're at the end of this VBR year where these processes have been implemented and these practices have been working on making these changes, we wanted to just take the opportunity to reflect and hear from practices who have done this. And I think it'll be especially interesting for those who didn't choose to work. Well, honestly, for both. For those who did choose to work on CGM, you can learn like what others have done and how that's gone for them. And for those who chose to work on a completely different quality initiative, it'll give good perspective as to what others have done in case this is something that you want to begin working on in your practice. So, Heidi, anything to add to that intro?
No, I think we have some good discussion points, so I'm excited to jump right in. So we can go ahead. My PO also chose the CGM quality initiative, so I'm eager to hear what others encountered. So Jackie, if we can go to the next slide. So today we have Peggy Best from Oakland Physician Network Services. We have Orchid Beatty from GMP Network. We have Juan Reyes from Olympia Medical Network. And then last but not least, Anne McGaffey from St. Mary's PHO, who will be helping us with this discussion. So for the first question, we're going to ask all of our panelists. And so I'd like each of you to explain your PO goal that you had around CGMs, the process change that you made, and if they were successful. So I can see both Anne and Juan right now. So Anne, do you mind going first?
Sure, no problem. Yeah, so St. Mary's PHO was already involved in an initiative surrounding CGMs called the Remote Patient Monitoring Initiative. So to a large extent, many of the processes were already in place, or we had already like piloted with 5 of our AMG clinics that were to varying degrees successful. The biggest of which is understanding when a patient who is diabetic is coming in, that is out of range, and discussing with them at the visit they're coming in at about different options that they might have surrounding gaining a CGM, meaning like whether it be prescribed or through our initiative program where it is covered through basically grants and other funding. And that I think was the biggest thing that made this successful. Considering that in a clinic, when a patient comes in to be seen by their PCP, there's very little time to really discuss a lot of, they have so many issues when they come in, generally speaking, and trying to gain some focus with a specific population within that clinic. Of course, the other obvious choice within these clinics were to really take a collaborative view. So it's not just the PCP and the MA that is seeing that patient at the time of the visit, but in addition to that, the care managers at that clinic, if one is available, and also myself outside of the clinic, making contact with these patients ahead of being seen at their visit. It definitely, it was more successful because patients had it on their mind. And it was something where I think many times patients who are out of range, they have so many issues that got them there. And sometimes they kind of fall through the cracks, not because their physician or their, nurse care manager, any of those people were not paying attention, but because the patient workload is so large, sometimes these patients need a lot of extra touches or, contacts in order to understand that this is something that their care team is interested in helping them make a change if they are interested in making a change.
Thank you, Anne. Juan, do you want to share your goal? Your PO's
Yeah.
goal?
Yep. Can you hear me?
I can. Yep.
That's sweet. Okay. So basically, kind of our goal generally was just to increase CGM prescribing in patients that are on insulin, because we felt it'd be like a good ideal target, just because we probably felt they could have the most benefit from a CGM, as well as we figured it'd be relatively easy coverage because they should get a CGM. Our changes were mostly targeted at kind of utilizing the data dashboard a little bit just to get like an initial list. And then from there, we can look at our own EHR and kind of decipher who would be appropriate to outreach to, as well as getting our offices a little bit more involved in that initial, identification of patients, whether they're rooming a patient or just kind of identifying those patients that could be good for our referral. And then getting members of the office more involved in ordering of CGM too, because myself and the other pharmacist, Marcus, we kind of do a lot of that. So trying to have other people do that too. But I would say we were relatively successful, I think, in terms of getting patients, identifying patients was fine and worked well, but getting them on our schedule, of course, is one barrier, but also just whether it's getting other members in the office to get that referral or to order CGM just kind of depends on their workload. So that was hit or miss too, but relatively successful.
Thank you, Juan. Peggy, can you share your PO goal?
Hi, everyone. Can you hear me okay?
Yes, we can hear you, Peggy.
Okay, great. So our goal was to increase the prescribing for those patients who had A1Cs 8 and above. And I'm not sure I have too much to add to the other presenters. I think our, approach was very similar. Involving the entire care team and identifying patients is essential. And so whether or not that identification comes from physicians, whether it comes from MAs, care managers, So, so that was very important. And we also developed an algorithm that described the ordering process. And I think I had talked about this on another panel discussion. One of the big glitches, one of the challenges was the ordering process. So we developed an algorithm that was kind of simply laid out, if this, then that. If a patient has this coverage, then this. If a patient is commercial or if it's Medicare, then we do this. So I think that was pretty successful. I have, kind of a lot more to add, to this. So maybe I'll just kind of wait until we get to our points. But again, I do think that we were successful. So maybe I could just, talk about some of these other things as we go along.
Yeah, that sounds great, Peggy. And certainly, depending on when we end, if there's time, I mean, if there's something we didn't get to, I'm happy to have you share. Orchid, I don't see you on my short list of names and faces I can see. Are you here? Jackie, did you get any?
Orchid, it looks like you're on the call, but you're muted. I'm going to press S to unmute. Okay, we will circle back.
Yeah, Orchid,
Hi,
perhaps you
I'm
can.
sorry, did you say Orchid?
Yes.
Okay, sorry about that. I had to dial in. I'm having internet issues, so I apologize.
No worries. We're
Um,
happy to have you.
Yeah, so for GMP, and our goal was to, similar to some of the other speakers, was really to just bring awareness to some of the processes for getting CGMs approved. I think that was one of our biggest barriers, and where some physicians just didn't understand what criteria was needed to be met in order to get a patient on a CGM. Monica Bridges, who is our initiative lead, she's done a lot of work with just connecting with the health plans in which we have a contract with, meeting with them to get details behind their process. And she has also created algorithms by payer. And she has worked with the clinical champions of the practice to implement those workflows. So I would say it's been pretty successful, especially those practices that have a physician and we also have a practice group that has a pharmacist on staff, and it's been pretty successful with that.
Great. So thank you. So it's sounding a nice theme of utilizing the dashboard to help support identification of patients, certainly perhaps going after patients that we know should have coverage, since coverage is so tedious and at times challenging. And then order panels. I know that's something that we did. I helped create order panels for the pharmacy. So everything was already there for sensors and readers and diagnosis codes. So anything we can do to streamline makes things easier. So thank you all for sharing. Jackie, I think we'll move on to the next slide. So for Juan and Anne, if you can share with us what worked well for you in trying to make the changes that you shared with us.
Yeah, I can go first. So like I said, just kind of thinking about the goal of trying to get more patients on insulin that are on insulin on a CGM. The data dashboard was definitely a good tool to use just because you can filter and you can find those patients that are on insulin pretty quickly. So that was just a good kind of starting list. And then from there, obviously, we're going to look at our own health record and kind of match things and reference it. So yeah, I think the data dashboard is a very good tool to utilize, as well as, for us trying to get CGM ordered or try to have a delegate, I guess, and other people to do it as well. I've talked about this before, but Parachute is a really great tool to use. So I think utilizing that has been a really big kind of game changer to get others involved, because I think well, I kind of talk about this later, but using that just to help consolidate everything and not worry about paper and faxes and all that stuff can help a lot. So I would say those two things helped a lot, the data dashboard and Parachute.
All right, thank you, Ann. Just as I'm remembering, Ann, before I turn it over, just reminding you all of some MCT2D resources that we have. So we have a Parachute resource. Juan and Bobby and a couple, Marcus are helping me currently update the Parachute resource. So a new one should be coming. And then two, previously it was mentioned about educating about everything that was needed, or maybe helping select the best patients for CGM. And so we do have a nice tool that kind of walks through some considerations for patients. So certainly go take a look at that. And if you need me to point you in the direction, I'm happy to do that. And hopefully maybe I'll put the link in here at some point if I have a minute. Ann, do you want to share with us your thoughts?
Sure. Well, our PHO does use an additional resource called Health Focus in order to create lists of diabetic patients that have upcoming appointments with A1Cs taken within the last year that are above 8 and over. And it's tracked by clinic. So that was already something that we were able to do. And utilizing those lists, in addition to the lists available through MCT2D, I think is critical to figuring out what like the lay of the land. What are you looking at? So just generally identifying those patients that obviously are struggling to gain control over their A1Cs. And because we already had a program in place called Remote Patient Monitoring Initiative, which was funded through Blue Cross Blue Shield, a lot of the barrier to utilizing a CGM, even if their insurance covers it, sometimes the copays or coinsurance would put that patient outside of a realm where they could afford it, was invaluable. Many patients, they would use it initially, sometimes every other month. So it was interesting when MCT2D came out with the toolkit, which laid out a very similar pattern to what it is that we were already seeing with patients. Ultimately, many of the patients that were successful utilizing the CGM, the key was their readiness. So making sure that the clinic had a care manager in place and the communication was like we closed the loop. So I would contact a patient. If they were interested, I would set everything up. And then I would also send information to the care manager and the primary care physician at that clinic, so that the care manager and the physician could have like a team conference. I know that's one of the G codes that care managers use. And in utilizing this, it just kind of completed full circle so that everyone on that patient's team had a good understanding of what was happening outside of clinic. And then, of course, scheduling regular visits, not just with their primary care physician, but also with the care manager. And then coordinating, the other key piece to this is diabetic education referral. I would say that's probably the most important, because many times patients, it was interesting to them to see, like, for the first 10 days what their readings were, but trying to piece out like what that meant in their day-to-day life. That would be where diabetic education and self-management really came in. And we saw many patients that were at A1Cs over 10, one of which was at over 14, come down to 6.2 within a few months. So that was a dramatic increase. And it was very successful.
Yeah, that's great, Ann. I think CGMs or glucometers, anytime you can make that data meaningful to your patients, that's when the aha moment happens. And so when we're able to have that aha moment, we see those amazing drops in A1C. So kudos to you. Jackie, next slide. So I believe this is for Anne again. So if you can share what was harder than expected with your quality improvement.
So overall, the hardest piece of this puzzle was the tech piece, to be quite frank. CGMs are great. Many patients have a seamless journey with it, and it certainly is easier now that because we were using Dexcom G6 for the study in particular. However, patients had a much easier time with the G7 when it came out because one of the issues is in tracking. The patient could many times see the glucose readings, but the physicians and the care managers may not be able to because the connection wasn't being made between the transmitter and the app. Like they would have the patient like installed it and it like either it was mistimed. It usually happened if a patient was slow to get their new sensor on, and they needed to switch out their transmitter. So there definitely was kind of a learning curve for patients, care managers, and to some extent some physicians with supporting that piece. Because it's difficult to do over the phone, but honestly, that's usually when you have to do it is over the phone with the patient. We also did have a lot like a steep learning curve to the patients that were not ready. So in our RPM program, many patients would be very excited and want to do it. They would get the device and have it installed and everything and discover that this really wasn't something they wanted to do for a variety of reasons. Or the patient was not ready to make those changes. So one of the things that the care managers and myself, we all took motivational interviewing classes, and that did help a lot. In addition to understanding that when a patient first is deciding to do this or not, that decision that they make is very timely. And sometimes if too much time goes by between when they can pick up a CGM device and then see a diabetic educator or the care manager, that it kind of goes by the wayside. Their life gets in the way, something happens. So there was a lot of circling back around to speaking to these same patients, sometimes months later, to kind of pick up where we left off if they were ready to carry forward.
Yeah, and I'm just curious if you could share with the group maybe 2 or 3 of those examples of maybe why a patient said this isn't right for them.
So one of the patients, his coverage is through Advantage, so it's Medicare, and Medicare, you have to go through DME for the most part. His plan required it, and the 20% copay that he was going to have to, or coinsurance that he was going to have to pick up was much greater than he had expected. An additional $140 every 3 months was outside of what he was interested in. In addition, in the first 10 days that he had the device, he had set up a number of alarms, and it woke him up in the middle of the night and it woke up his spouse. They decided that was not for them. However, he did decide to go ahead and test more often with his glucometer. So
that worked out.
Yeah, I think because so many people in that office were talking to him and he had like a better interaction than about his diabetic care and an understanding that it was important that he was still able to make some adjustments and change.
Yeah. I think what's important for the group to hear is, as much as I've said, I know I've said this a million times, I'd love every patient with type 2 diabetes to have a CGM. I do think it's important to recognize that it isn't meant for everybody. And some patients might not like it. Another example I've had is it was just too much data. It was data overload, and the patient almost became very obsessive over their readings. And so I think there's a balance, but for me, kind of the motivation part is key. And if I have a motivated patient who's ready, if I can get a CGM in their hands, again, that's when the magic happens. So thank you, Anne.
Yeah, absolutely.
All right, so next slide, Jackie. Let's see, this is for Juan and Orchid. So if you each could give us advice to give to other practices on how to implement these changes.
Yeah. So I guess just kind of thinking about ours, like our goal in the sense of trying to incorporate multiple members in our office to, you know, whether it's going to be the finding patients or ordering CGM via parachute. I think it's super general, but communicate. I think that's like the biggest advice I'd have. So whether that's like weekly huddles, bi-weekly huddles, care conferences, whatever, I think it's just really important to set time aside, whether it's like before clinic starting or what, 10 minutes, but just communicate on like what's going well, what's not going well. That can help a lot and kind of get things moving, especially like when you're just starting out with a process change like this. Get it established, you know, those meetings, like I think it's important to do it quick rather than space it out every couple weeks or something, because then, you know, it just falls by the wayside. So yeah, I think that's probably the biggest thing I would say. And then when it, again, back to like ordering CGM, I think just parachute, that's just I've said it multiple times. But whenever, I think it's kind of even switching a little bit to patient's perspective on getting them kind of what was just mentioned about getting them motivated to use a CGM if maybe they're not, or if they're still hesitant about it. I think trying a sample, I don't know what the vibes are with reps or anything, but I think just trying a sample can help a lot, because I think once they try it, and of course education, I think educating the patient, putting it on them in the clinic is huge if you're able to. That way they can, you know, do it right the first time, because if we had a bad experience putting it on or whatever, that can be not great moving forward. But I think samples can help, at least 2 weeks or something, just to see how they like it.
Yes, if your entity supports samples, then
If you're able to, yeah.
Exactly. Yeah. All right, Orchid, what else would you like to share with us?
I think one of the things that we try to do at our PO is help the physicians and practices see how some of the initiatives, especially through the Blues, can kind of work together. So, for example, with PDCM, we know that we get that Blue Cross list. We create a comprehensive care management list. We include some flags on there, so individuals with like A1Cs, their blood pressure, and so we encourage the practices to just try to create workflows that'll help them achieve multiple initiatives. So for one of our practices, because they do have a chronic disease management team, they are utilizing the care management report. We have pulled in some of the MCT2D dashboard data into that care management report. And at morning huddles, they discuss with the doctors and APPs potential patients to engage in care management. So just taking that opportunity during face-to-face. And then they also do their own kind of cold call outreach. So that has been pretty good, because it just doesn't make them feel like we're asking them to create separate workflows, but actually a seamless workflow that helps them achieve outcomes and multiple initiatives. I think the other thing is just continuing to find resources. I think later in the presentation you'll ask the question, but just trying to hear them, what they're asking for, and trying to find additional resources to help them, implement the CGM, support the care management team members.
Yeah, thank you, Orchid. So I'm hearing a theme. So communication, I think, can go around so many realms. So workflow, kind of a communication. I think the only thing I would also bring up is I ran into this week in clinic is communication of troubleshooting DME rejections. So I saw a patient yesterday that I prescribed a CGM back in March, and they hadn't received it yet. And I had gotten zero notification from anybody. So just trying to figure out, it got me going with like, where was the pitfall in that I didn't get any sort of notification. And I did relay to my patient, hey, if I ever prescribe you anything and you don't get it within 10 to 14 days, please notify me. But yeah, so the theme of communication. All right, Jackie, next slide, please. So Juan, this is a long one. So we all know there's competing thoughts, and this isn't exactly easy of getting things accomplished. So if you can share what barriers of opinion you faced in getting your QI arm going, and how did you achieve buy-in?
Yeah, so I would say for us, I mean, it's overall very well perceived, but there are some providers just even initially buying into using CGM. So that's something that's challenging. But some of the things that we've heard is that they don't have time for office staff to do PAs or insurance coverage. Not sure about that, but I really think it's just like lack of education on CGM and not really understanding like their full potential. So like our role, I don't know if everyone, I mean, probably not, but has like a pharmacist in their clinic, but our role is pretty unique in that we can prescribe under a collaborative practice agreement. So for these providers that maybe don't have as much education or aren't as comfortable with them, we've kind of taken on that of prescribing them and getting them started, managing them. So to kind of help with that buy-in, we have, like I mentioned before, we'll have our care conference or weekly huddles or, even in between patients where we'll show them the CGM reporting, whether it's A1C reduction or just showing them like the decreased insulin load, just all of those things to really show the significance of the CGM. And, even when the patients go and see the provider, just they say how much they love their CGM. I think that really kind of has, in and of itself, has just shown the buy-in, just the data and the results. So that on top of like the weekly huddles of just kind of addressing how well they work for patients, and it's kind of done the opposite. Well, now it's like we're getting too many referrals for CGMs, and they're kind of recommending CGMs for everybody, but now we have to back off because insurance coverage and stuff. But really, I think just kind of showing them the results has been a huge difference.
Yeah, it's a good problem to have one. So love promoting role of pharmacist. So I think it's also nice just to be the team. So I know at my clinic, my physicians appreciate just the team effort. And so it's, they can rely on looking at my notes and me seeing the patient more frequently and really concentrating on the CGM. And then when they see the patient, they can briefly go in and look at that CGM report, but then focus on the 10 other things the patient wants to talk about. There was one other thing I was gonna bring. Oh, I wanted to also put a plug in for the user experience, the CGM clinician user experience. I have found myself having done it, and then also having a couple of the physicians in my clinic where it's eye-opening. And so I think that comfort level becomes much more comfortable when you've actually worn it and seen it, and you can see with the app. I now know being woken up in the middle of the night from an alarm. I can appreciate from my patients when the wife of the husband says, I can't stand this thing. So, I get it. So I think that's important. Well, thank you, Juan. Jackie, next slide. So this is for Peggy. If you can share with us what your biggest takeaway was from this process.
So I would like to echo many of the points that the other presenters, have discussed. I think the biggest takeaway from this process was, and this is, I guess, a good problem to have, is that through this journey and learning about the CGM, we have realized that just about every patient who has type 2 diabetes could benefit from this. Now, given the coverage issues, that has become, very frustrating because we see the benefits, of this, not only for those people who are on insulin and maybe are in an uncontrolled state, but even for those patients who are pre-diabetic, right? This is just, I had one patient say to me the other day, this is a game changer. There is enough data for her to understand and realize what factors affect her blood sugars. How does exercise affect blood sugars? How does my medication? And most importantly, how does my diet affect my blood sugars? So that is one takeaway. And hopefully, as we move forward with this, maybe coverage would change. We'll see what happens. Another big takeaway, I think, is the importance of defining roles and responsibilities. The other presenters, and we have talked about this, have said, maybe the ordering process is arduous. Well, we have found that educating, specific key staff members to manage the ordering process, which, to your point, Heidi, which would include follow-up, is very, very important. I'm sorry, I'm just kind of looking at my notes. The other big takeaway, I think, was the importance of devoting time for education. So, we go through determining who is eligible for a CGM. We talk about it with the patient. We order it, that is successful. And then we bring the patient back into the office. I think that this is essential, to assign training, again, to a key staff member. Most of our care managers are responsible for this, making sure the training is comprehensive, not only letting patients know, how to do a measurement, but to talk about the report viewing. How can these reports help you with goal setting? Where are you now, as opposed to where were you a week or even a month prior to this? Assisting with insertion, having the patient come back for another insertion demonstration if needed. And then also troubleshooting with the patient, and these kind of troubleshooting, I think many times we learn accidentally or incidentally, but assuring the patient that they have support in the office and that the office believes in this device.
Yeah. Thank you, Peggy. So again, this is like beautifully sequenced in terms of themes. So communication, education, and teamwork. So I think the process of CGMs, you can't do it alone. And so the more that we can involve the team, the better off the patient is. Jackie, next slide. So this is for Anne and Orchid. What changes in your practice planning do you plan to implement next? I don't know who wants to speak first.
I can certainly go first.
Sure.
So I think earlier I had mentioned that, or someone, I think I mentioned too, that we're going to implement a new process, and someone mentioned sometimes it's discussing troubleshooting. You have the workflow, you have the prior authorization requirements down, but sometimes there's still just kinks. And I mentioned just making sure that we're in constant communication with our practices and trying to identify resources. So recently, we developed a relationship with a company called Advanced Diabetes Care. And they will help practices and even our internal GMPN's internal care management team with prior authorization. So while we made sure that point persons in the practice have access to Parachute, whether that be the medical assistant, elite medical assistant, a chronic disease management team, a pharmacist, we still heard that sometimes we didn't get a response back, or we provided all the needed documentation and it's still getting declined. And so with Advanced Diabetes Care, they will take on the responsibility of gathering the documentation, authorization, communicating back to the practice or the GMP and internal care management team if there's issues such as needing more documentation or kind of explaining to the physician what was missed in the documentation. They're going to provide that support. They will also do the outreach to the patient. So it is something that, once a referral is made to advanced diabetes care, a care management team member or physician have to explain to them, what is the next step. I submitted this information to this company. Expect a call within that next couple of days. You have to give approval that they can submit the prior authorization on your behalf. They're going to contact you and let you know that once it is approved and what you need to do going forward. So we've introduced this company to our practices. They're very much excited. We have one physician lead, Dr. Fisher, who is ready to just start working with them. And GMP, and like I said, our internal care management team is going to facilitate that for him, just so that we can make sure that the process that was communicated to us goes as according. And then we're going to roll it out to other practices so they can use it independent of us, or they can continue to use us as a support.
Thank you. Okay, there was a question in the chat. What's the cost associated with this program?
There's absolutely no cost. So it's one of those things where it's too good to be true. Our internal care management team member, she has a relationship with, oh my goodness, I'm gonna, Libre, Resell Libre. She has a relationship with one of the reps. And she expressed, I'm still having some hiccups, we're trying to troubleshoot this issue. And he says, I think I have a resource for you. This is kind of like out of my wheelhouse. And so I want to connect you to advanced diabetes care. And so they do not charge for the service. It is a line of business that they want to provide to companies. It's not really known, or not companies, but to physicians and groups like us. It's not really known, so they're just committed to making sure that patients who can and should be on a CGM, they actually get on, because I think just like everybody else, they recognize that there was a lack of information, different prior authorization requirements that, prevented a patient from getting on a CGM.
Wow, it sounds too good to be true, but please keep us posted of how your pilot with Dr. Fisher goes. And maybe, I think there was a question in terms of how do we get this from Jane. So perhaps if, Orchid, when you have a minute, if you want to respond in chat for any contact information.
Yeah, I can certainly pass the gentleman's information who we met with. Very helpful, very nice. So I'm sure he would be more than happy to work with anyone who's interested, just at least to get information going. And then definitely as we continue with our pilot, we will let you know the success and hurdles that we may encounter or may not encounter, but we'll definitely keep you posted.
That'd be great. Thank you so much, Orchid. Anne, if you want to share your thoughts on what's coming next.
Sure. We have a few things that we're looking to implement. One is the RPM initiative that had begun is sunsetting, but the PHO is looking to self-fund this initiative, supplying basically covering the cost of a CGM for 90 days ourselves. So that's in the works, and that would be to all of the clinics that are involved in our PHO. In addition, the role of care managers has really stepped up in all of the clinics and they kind of stretched thin, unfortunately. But we're hoping that there will be more care managers hired to fill these roles in clinic, and working with each of those care managers to develop a workflow plan. There's a lot in flux as far as like the EHR we're using right now may change, that kind of thing, but just kind of have to roll with it.
Yeah.
The other is the PHO is looking to hire a pharmacist. Yeah, we really think that would be an incredible ad for clinicians at every level, not just for diabetes. And then one of the things that we did implement towards the end of this RPM initiative was there was a huge need of more communication between diabetic education and the clinics. In many cases, patients were being referred to diabetic education by fax. As you know, this is the way this is done. And if they didn't get like a confirmation, which is what the process was, it may go unnoticed because the lack of something is not usually a good indicator that maybe I need to follow up. So instead, there was documentation that was shared between Diabetic Education Center and each clinic so that when a referral was sent, there was an additional message, and therefore that loop is being closed. In addition, like with our PM initiative, I was in direct communication with the educator and very involved in getting these patients scheduled, finding out if there was like an issue as far as when a patient could be communicated with. As you know, like patients they have very busy lives just like everybody else, and being only having contact with a patient between the hours of 9 and 5 just in many cases doesn't work. So just making sure that that loop was closed. So that was a more recent change, and it's been very successful at making sure that these patients are being followed up with appropriately,
Yeah.
so that they're not slipping through the cracks.
Thank you. So again, that theme of communication, right? It all comes back to that.
Yeah.
And good luck with getting that next part of the project off the ground. So fingers crossed.
Yeah, thank you.
Yeah, Jackie, next slide, please. So for Peggy and Orchid, we'd love to hear what your thoughts are on what is needed from a policy perspective to reduce the friction and make it easier for your practice to operationalize CGM prescribing and interpretation as part of your standard workflow. Who would like to go first?
So this is Peggy. I think I could go first. I really believe that lobbying for better coverage is key. Again, through this journey, we have found that most every patient who has type 2 diabetes can benefit from this. So lobbying for better coverage, I truly think that this is probably the most important thing that we can continue to do and work on for our patients.
Well, know that we are working our tails off at MCT2D to do this. So hopefully more good things to come.
Thank you.
This is Orchid. I had a similar comment. Jackie, this is actually something I think Monica and I shared with you during our 101, and that is just making the criteria the same, if possible. So, even if it's for all MA plans, this is the criteria for all commercial, for all, the Medicaid, that would just be really helpful. Because when you do have those small nuances, I think for Blues MA, they say, a patient just needs to be on insulin. You don't have to prove history, but with Priority Health, you do have to prove history. So it's those small things that when a physician, provider, they just want to help their patient. That's where the frustration comes in, or it all to the patient. So it's a great idea that the physician has to patient on board with, they're ready to go, and then, you know, whether it be handed off to a care manager or the MA to continue the process, you know, some of the bumps along the way can be discouraging. So if at all possible, just encouraging to make a seamless prior authorization requirement by line of business, and then with hope of just having one universal coverage criteria.
Yeah, hopefully more liberal coverage criteria would be nice. We're going to work on it. We're going to keep poking everybody and saying this is what we'd like. All right, so to wrap us up, Peggy, there's one more slide coming. So love to hear your thoughts, and maybe after Peggy speaking, if we still have a couple more minutes, anybody on the call, what is one thing that you'd like us at MCT2D to help achieve your goals in terms of appropriate use of CGM in your patients with type 2 diabetes?
You know, so again, I think continuing to help us with coverage, I really appreciated your point, Orchid, you know, and if we can't get expanded coverage, maybe we could at least get a little cleaner type, consistent coverage. I think MCT2D gives us a lot of very good information in terms of patient identification. I do believe that maybe even continuing to provide resources for patients in terms of maybe even lifestyle changes as an adjunct to CGM use. You know, and I was even kind of thinking developing generic patient guides for CGM use. How does this device help? Report viewing. How does this help with goal setting? But I think overall, MCT2D is doing a great job in supporting us. I know we really enjoy the continued patient resources that come out.
Thank you, Peggy. And for those of you that were not able to join us for our regional meetings, we definitely had some exciting announcements coming with Coverage Tractor. It's going to be interactive, and so we're focusing on CGMs. So we hope to get this released next month sometime. So I'm hoping you all will be very excited about what's yet to come here. So that is on the way. So we have 7 minutes left. Yes, thank you, Stephanie. Any other thoughts or comments that anybody wants to share?
This is Peggy again. I have one more comment in that I think it's very important for offices to obtain the viewing platforms, whether it's for, you know, the Dexcom, which is Clarity, or if it's the Libre View. So I think that helps care managers and physicians and the whole care team. You know, when we go back and take a look to see how a patient is progressing, it's an opportunity maybe to either continue to reach out to patients to give positive reinforcement, or to take a look and say, oh, gee, maybe this person needs more help or needs more education or another touch.
Yeah, no, I agree. So I find those vital to my service and connecting with the physicians I work with. So yes. I'm just trying to catch up with all the comments. Looks like some more praise about Coverage Tool. Dexcom is offering samples on the website. Again, if your institution allows that, mine does not. Anything else, or is it time to say Happy Memorial Day? Please give me the number again. Hopefully that's there.
Yeah, yep, I just put it in. So anyone who missed that CME number, it's now in the chat with what you text and the number you texted to.
All right, thank you, Jackie. All right, well, I just want to thank our panel members for taking the time before a busy holiday weekend. So thanks for preparing for this. And thank you for sharing all of your thoughts. And I hope you all have a wonderful holiday weekend.
Thank you.
You too. Bye-bye.
Bye, everybody.
Bye.